I think we can now begin. Good afternoon to everyone, and thank you very much for your time. I see that colleagues from different countries in the region are joining us. Most of the presentation will be in Spanish, and we'd like to thank you once again for your time and your presence this afternoon. This is a very important event for us because we are currently going through a process that began some time back with some colleagues working together, trying to find information to how it is possible to attract, recruit, and retain health personnel. This is an outstanding topic. It has been around for some time, and we want to offer and look into different options. So launching this document, attracting, recruiting, and retaining health personnel in rural, remote, and neglected areas. For the time being, the document is only available in Spanish, but it is going to be translated into English. Hopefully, it will be available in the very near future. And Dr. James Fitzgerald has asked me to convey his apologies. He is the head of the Health Systems and Services Department, and he's at the head of the Human Resources for Health unit. He would have truly liked to be present at this event, but unfortunately couldn't. And because of that, actually, we had changed the date in the past. But there had been a very specific request by the director asking him to represent her at a meeting, and therefore he had to apologize to us. He could not be present with us, and he asked me on his behalf to share with you a brief presentation. Let me share screen, and it will be on human resources for health and achievement of the universal health goal. Hopefully you can now see it on screen. We had asked Dr. Fitzgerald to provide some backdrop as to the human resources in the region to achieve universal health, which is universal access and health coverage. Health reforms carried out throughout the region, and this goes back to the 1970s, last century, and through today, include health as a right. Nonetheless, in the region of the Americas and the Caribbean, over 100 million individuals still do not have access and are not part of the existing systems, according to a publication dating to 2017. I believe we're all aware of the strategy for universal access and health coverage. This was approved by all member states, where everyone approves and even accepts, and this includes us in all our documents, at all our meetings. We recognize the need to provide universal health. But I think it's worth looking further into the definition of access. According to the document, access is to eliminate barriers. Those barriers that still exist, these may be geographic barriers, financial barriers, cultural ones, even language barriers. And when we look at maternal mortality, there is a third or last barrier that is mentioned. That is when the patient reaches the health services and cannot find staff to take care of them, or if they do find the staff, that staff is not properly trained to provide quality service and care. When we look into the meaning of coverage, here it talks about having available the necessary infrastructure, equipment, medicines and drugs, and all the resources, including human resources. But with these resources cannot be effective unless there is a group of healthcare providers that are sufficiently trained to use those resources. So in order to move towards universal healthcare and universal coverage, it is absolutely necessary to have human resources in sufficient number, properly distributed, having the right profile, quality, and skills adapted to the country's health system. Much has been written to develop all frameworks relating to healthcare human resources. And we're obviously going to continue working on this matter because rather than being a target, it's a process. And amongst the most recent documents approved by member states, we have the human resources strategies to ensure universal access and coverage to health. In item 24, paragraph 24, it talks about the need to implement strategies for retaining health personnel, especially in areas that are underserved and that will depend on the intercultural characteristics of each community, combining economic and non-economic incentives to promote the development of this personnel. In the document with the action plan that was approved the following year, Objective 2.1 specifically addresses the promotion of fair manpower and retaining health personnel through developing professional and economic incentive policies. In this objective, there are three indicators that the countries need to work towards implementing. One is to develop professional development policies. Another refers to economic and non-economic incentives policies, and at least be able to have as a goal 25 healthcare personnel per 10,000 inhabitants in neglected areas. Although the document is a little bit dated, but it is as applicable today as it was in mid-2000. Dr. Margaret Chang, at the time, stated that practically all countries, both rich and poor, face a critical scarcity of competent health personnel in rural areas where the need for basic care is that much higher. These graphs show the distribution of global population. 50% live in urban areas and 50% in rural areas. Let us not forget that although 50% live in urban areas, within these urban areas there are some areas that are difficult to access or they are perhaps neglected. because there are safety issues, there's a lack of infrastructure, and they are difficult to reach. Likewise, health personnel distribution at the time, and I think this remains valid today, and later we will actually see that the percentage of nursing staff in rural areas, and here it talks about 38%, but I believe today it is less than that. But the group of doctors working in rural areas is less than 1/4 of the total number of doctors. In a more recent publication from the International Labour Organization, a document dated 2015, it points out that 56% of persons living in rural areas do not have access to basic healthcare services. This is more than twice the group of people living in urban areas. That very same document further says that even when access to medical care is guaranteed by law, people living in rural areas are excluded from medical care. The situation is aggravated due to the lack of health professionals in rural areas in the world. And although half the population lives in these areas, only 23% of the labor force actually works in those areas. At the time, 2015, it was believed that 10.3 million health workers was the existing global gap. And in this group, 2/3 ought to be appointed or assigned to rural areas. And the two regions that are most afflicted by this problem are Africa and Latin America. This is a graph that I mentioned earlier, but you know that in 2016, the Sustainable Development Goals were drafted. The analysis there showed that the gap is perhaps even more significant than the 10.1 million previously mentioned, and that it was actually perhaps 18 million health workers as of what is expected for the year 2030. In this graph, we can see differences between rural and urban areas in 4 dimensions. One of these, perhaps the most important, is financial, in addition to the legal deficit of such coverage. And then obviously the dimension of due to human resources. And this is a marker for coverage and access to health. For that, we have maternal mortality. In rural areas, it is practically twice as important as compared to to urban areas. This report is a little bit more recent. It's the World Nursing Report 2020. As you know, that nursing staff represent over 60% of health professionals. This report, based on 35 countries who provided broken down information, broken into rural and urban, and here we can see that the group of nursing professionals in rural areas is declining. In 2006, we already saw it was 38%, and in 2020 it's down to 36%. Whereas the population living in rural areas is about 50%. In this report, they mentioned 49%. So if we want to achieve universal health, and this is the mantra that we are constantly repeating, we agree it is a necessity, then it's very important to have health workers in sufficient number, properly qualified, available, and willing to respond to health demands of population, especially at the primary care level in rural, remote, and neglected areas. The state plays a key role to develop health policies with intervention strategies. I'm mentioning this because in the process that I mentioned at the outset, although we began working doing a systematic review, the ultimate goal is to end up with a policy document that can be shared with the countries in the region so that they can view the different intervention strategies that they could contemplate implementing. Thank you very much. I think that was my last slide. So I'm going to stop sharing screen and let me now invite Dr. Sulma Ortiz to give us her presentation of the document. Dr. Sulma Ortiz and the team she works with, these includes Dr. Laura Antonietti and Dr. Maria Eugenia Esandi. This is the team that worked on the systematic review, and she is still working with us in this process to develop the policy document. She works in the Academy of Medicine in Buenos Aires, Argentina, in epidemiology. She's the former health minister of province of Buenos Aires in Argentina. Sulma, you have the floor. Good afternoon, and thank you very much, Mali, for offering me this opportunity to share with you our work. Let me share screen. Let me try again. Hopefully you can see my screen well and clear now. Yes, we can. As I was saying, as a team, we want to present the work that we began 3 years ago. At the outset, the Pan American Health Organization, through the Human Resources Unit, coordinated by Mali and with collaboration by Jose Francisco, Mr. Gutierrez, and Isabel Sure, we created a team that always aimed to develop a policy document that was evidence-based, but also focusing on the region of the Americas. We decided to generate different outputs that ended with publication of articles in the Bajo magazine, but also meetings with experts in human resources in order to tackle this issue, how to improve attracting, recruiting, and retaining health personnel in rural, remote, and neglected areas. Over this time frame, not only have we developed a scientific document, but we have worked as a team. And let me point out that thanks to Jose Francisco's participation, it took into account the work done by the World Health Organization in order to harmonize the scientific evidence that had to do with this topic. In addition to this goal for the output, we had a need, and we shared this, to not only develop or obtain theoretical and empirical scientific information, but also to have an opportunity to dialogue and discuss these specific policies that are then translated into plans and programs by national governments. In other words, this meeting opportunity, which was called a deliberative or discussion dialogue, is the ultimate body And we're now close to, and I will be explaining the process in a moment. After reviewing all the empirical evidence as to how to attract, recruit, and maintain personnel in rural, remote, and neglected areas, and after looking at the context with colleagues working in different countries of the region, the executive summary that Mali referred to, and it's now available in Spanish, will be published. It has been shared, and we will continue sharing it with colleagues who will be able to respond to a survey, the goal of which is to help us complement this evidence that we have sought out from scientific publications, but aware of the limitations in the region, frequently and unfortunately, some work is not published, but it is known and recognized by colleagues working in different areas, and they know about the problems in attracting, recruiting, and retaining health personnel. So it's important to complement the scientific evidence with the experience and statements by individuals who in different parts of the region can actually see everything that Mali described when looking into the situational diagnosis and analysis. The opportunity for discussion will therefore provide us an opportunity to complement our theoretical and empirical evidence with actual real experiences and be able to have a summary that will ultimately be a policy summary, providing guidance to governments, but all the players in the system who are occupied and preoccupied by the critical situation that was diagnosed by the United Nations system having to do with the scarcity of personnel in these areas. As I mentioned out, thanks to Jose Francisco's help, and he's been working with the WHO, we were able to harmonize the scientific evidence that we gathered with the work that has been carried out by the World Health Organization this past decade. The goal has always been to find the highest level scientific evidence, as we pointed out, in addition to what has been reviewed in the scientific publications by WHO, add to this the primary experiences throughout the world. Now, what we did, though, was to focus more and emphasize more on our region.
The work of the World Health Organization has enabled us to arrive at a recent publication in 2020 and in 2021, a guide for clinical practice, which summarizes all the interventions which have attempted to prove to be effective in order to tap, retain, recruit, attracting, recruiting, and retaining health personnel. So essentially, what this is about is to arrive at a document that harmonizes the work done by the World Health Organization, where we've seen greater reach in geographic terms with the inclusion of primary studies and with the development and drafting of recommendations. And on our part, greater emphasis in the region of the Americas with utilization of reviews and arriving at this summary, which is the document known as the executive summary or policy brief, which will enable us, and this is our interest, to guide policies, plans, and programs to be carried out essentially by us. So, in a very summarized fashion, in order to give some time for questions, because this material will be available, we could say that our contributions go along the lines of theoretical evidence, as you can see here, where we come after reviewing conceptual models in connection with those factors that would be playing an essential role when attracting, recruiting, and retaining health personnel. And at the same time, for that personnel to become a whole set of stakeholders that are healthy, motivated, pleased, and carrying on their work with the adequate conditions. This model was published, as was already mentioned by Mali, in the Pan American magazine, in the Pan American Health publication, and it is used when we come to beginning the drafting of a policy by envisaging all those factors that one way or another can determine this attracting, recruiting, and retaining. So, taking into account that this conceptual model that has a purpose that is not necessarily academic but pragmatic, when we come to having in one single chart, one single graph, all these factors, that is how we started reviewing those interventions that have proven to be effective, as I said previously, for attracting, recruiting, and retaining health personnel. In this way, and in a very summarized fashion, we could say that following the classification of the World Health Organization, interventions can be divided into four sectors. We have educational interventions, we have regulatory interventions, those that work as an incentive, and those that look for support and supervision by personnel in these areas. That is to say, rural, remote, and neglected areas. If we have to say in a couple of words what we have by way of evidence in order to assess educational interventions, we have the need for dividing these into those that are implemented during the training of the human resource, that is to say, in different levels, and those that have more to do with professional development that was referred to by Mali. For these first, that is to say, for the people that are being trained, we have those policies, admission focused policies where we try to expose the students to these conditions, this work environment in rural and remote areas. And then we could say that this is an extensively studied topic, and where the certainty that we have with these interventions from moderate to high, and where the greatest effectiveness is seen when we attract or recruit. So, in synergy with other interventions, any initiative that is done from the sector, from the health sector, with that of education, in order to train the personnel in these areas, in keeping with what we have by way of evidence, there is certainty and has been extensively studied. However, when we come to seeing the viability that this intervention can have from the health sector, we see that there's a complexity that arises that has to do with intersectoral work that is necessary in order to continue moving forward with these rural programs. And the same thing happens, and even being more complex, when the definition goes along the lines of establishing offices, or in many cases, even a university in these areas, with the changes of curricula, the bureaucracy that in itself we already see in the educational system, plus the major investment that is needed by these interventions, according to what evidence has proven. And it would not have a relative ease compared to what could be a focused admission policy. We see this as more complex, relatively more expensive, because there's a greater investment to take place. And once again, it works better when tapping and not so much when retaining the health personnel. Better when we recruit and not so much when with retaining. If we go to the development of health personnel, therein essentially what we see, and this is what we were able to observe in scientific evidence, is that this has been broadly studied, particularly with medical staff and with those that are specifically doing their residency. And the certainty, and this is moderate, in this case, we found a high certainty in order to be able to recommend an intervention specifically. And what we could also point out is that this thing about exposing professionals, residents, or physicians or doctors in these areas calls for a careful treatment of all these conditions in the work environment, because in many cases, interventions could fail when dealing with the care that is needed. And that is why it is important to go back to the conceptual map in connection with this organization, employment conditions, and work environment conditions. Last but not least, as regards educational interventions, what refers to professional development and ongoing permanent education, we've also studied this, and the certainty here is low so as to make a recommendation. It is necessary, if you wish, not only to investigate further, but to bring about programs that can provide us with a level of evidence that would enable us to offer recommendations. Now, going into the regulatory interventions already, we could say that in all cases here, the level of certainty vis-a-vis the evidence that we show is quite low, practically negligible or non-existent. Regulatory interventions and also interventions of support and supervisions are two areas for further research or research and implementation, or concentrating or focusing before we begin a policy or we launch a program, because we do not have scientific evidence, sufficient evidence, so as to make a recommendation on this. Perhaps with the survey and with the participation of colleagues, the evidence, the experience, and the living experience can maybe shed some light as regards regulatory interventions. And in here, in many cases, we've seen evidence and we've even heard with the work done by colleagues that everything that has to do with the mandatory service, there are places where there are laws that compel a resident to go through the last year in certain areas. And this has been widely studied, but we do not have impact assessments that we have in these mandatory services, and then the certainty of the evidence is quite low. There is a lot of controversy in connection with mandatory services when we try to harmonize this with the workers' rights. So, in a nutshell, everything that has to do with regulatory interventions is a vacant space for research and for exchange as regards how to guide the regulatory policies to regulate practices. And in connection with educational interventions, clearly in these two packages, educational interventions, in spite of the complexity implied in intersectoral work, they show a body of evidence with a higher certainty than those of regulatory interventions. Now, moving on to interventions that have to do with the incentive, different from the other two that have been broadly studied. And in fact, we were seeing with Mali that even in the official documents that we already see a recommendation regarding their use, combined with other interventions with raises the attracting and recruiting. It not necessarily has the same expected impact. This means that the recommendation is to use these packages of incentives with other interventions. That is to say, not to use only one incentive, but to bring together a package of incentives that would consider not only financial incentives, but also non-financial incentives. Although the certainty is low, so much has been studied that in relative terms, in connection with the regulatory and the educational interventions, in the case of incentives, we can feel comfortable in recommending these interventions. I insist because this has been broadly studied. Last but not least, interventions linked to support and supervision start off on the basis of an assumption, essential assumption, where it is necessary to invest in infrastructure and services to ensure a safe work environment and the conditions of a professional work. No support and intervention is going to work if these three elements cannot be ensured, if they're not a given. So here, although there's space for evidence on the impact on attracting and recruiting, regarding the progress made, particularly in information technologies, the support and supervision are more possible in relative terms to what one could have thought 20 years ago. But we insist it is not sufficient to have the support of specialists through telemedicine if we do not have the conditions on infrastructure, safe and decent work in these areas. So we'd like to emphasize this a lot because we've heard from colleagues that many a times the emphasis is played on the progress made with new ICTs and the situation in which they live and they work. The colleagues in these remote and neglected rural areas are not the best. So the support on supervision does not work, not only because of the technology and the specialists available are not good, but I insist because basic conditions are not given. And with this, and very briefly, we wanted to summarize the four categories of interventions, leaving some space for a dialogue so that you can ask your questions and so that we can emphasize the importance that this has, the participation in working on this survey and a new meeting place so that after having collected this evidence, testimonies, experiences, so as not to leave anything out, we can now have this executive summary that will summarize the entire evidence, experience, empirical and practical, to guide our programs and plans, essentially towards the government sector, without this and not implying that other stakeholders in the system can use it in the decision-making process. Thank you very much. And we expect to hear your comments. Thank you very much, Sulma, and the team for this presentation and the process that was carried out in order to prepare this document, as well as all the information that we were able to get on the basis of that review of all publications and the discussions with our colleagues. We still have some way to go, so we will follow this closely. Before I give the floor to Dr. Jorge Francisco Meneses, I want you to know that in the chat, and you can find this at the bottom of your screen, you can add your comments or your questions if you have any, or at the end of the presentation by Dr. Meneses, we will give the floor depending on the availability of time. So therefore, you will be able to raise your hands. Let us now give the floor to Dr. Jorge Francisco Meneses. He's a Vice Minister for Health, for Hospitals at the Ministry of Public Health and Social Assistance in Guatemala. He is someone who has a broad experience in managing health services because of the positions he's held previously and the work done within the Ministry of Health in Guatemala. So we kindly ask him to talk about the strengths and the challenges in order to attract, recruit, and retain health personnel in rural, remote, and neglected areas in Guatemala. So thank you very much, Doctor, for your participation, and you now have the floor. Thank you very much. Very grateful for this space. For Guatemala, this is extremely important because it will provide us with the possibility of describing the challenges and the strengths that we have in this field. The issue is extremely important as a country. We see this issue as something quite concerning. We've worked on this for many years. We've taken some actions that we consider to be quite important, or they have been seen as quite relevant. However, as has been said previously, the results have not always been the best. Very important that this issue of launching this discussion paper on how to attract, recruit, and retain health personnel in rural, remote, and neglected areas. And we in Guatemala would like to begin by saying that in order to take care of the health needs of the population in Guatemala, human resources and skilled workers is a very important factor. However, this is determined by many other situations that limit the ability to endow centers with a human resource that is truly needed. Let us begin our presentation by emphasizing the strengths in what we see as a ministry, what we've done in recent years. And we could say that for the Ministry of Health, over the years, where we've strengthened our capacities and we've had coordination with other sectors, it is very important and quite valuable for the Ministry of Health. And they've even developed strategies that have enabled us to make progress in this regard. The opportunities that we've had in order to train physicians and health personnel at the pre-graduate, graduate, and postgraduate levels has been quite important, opening the career of physicians and surgeons in other parts of the country. We've also strengthened the hospitals in rural areas, and many of these quite remote from urban centers where we do have district hospitals. We have been able to bring pre-grad students to these places so that they can start having their hospital practices in rural areas, and they can be in the context which is their specific area. Likewise, these pre-grad students have the possibility of also working in rural areas with the first levels of care, not specifically in hospitals, but in rural areas, in centers and different health clinics that place them in the real context and environment in the country. We've also had another opportunity to train or to bring these training students and nurses to remote areas, rural areas at a BA level. And recently, with the support of international cooperation, the training of university midwifery techniques and technicians that are focused in rural, remote, and neglected areas, and that currently are staying in these areas, already working with tax facilities that the ministry has been able to open up and provide in these areas. Some international agreements that we've entered into, specifically with the Cuban Brigade. Through them, we've been able to open up spaces in the rural areas, and we've been able to take care of the population that has needed the health services. We've also implemented the number of spaces in remote areas with specialist physicians working in cooperation with the universities in residency programs in order to bring specialists to these remote areas, as well as neglected and rural areas and with hospitals, and now with some non-hospital health services. The challenges that we've faced are also significant and maybe even bigger than the strengths, but we know that one of our greatest challenges in the country is the level of poverty. The capacity that our population has to be able to have access to a safe job makes them participate in many places where they can have several jobs, hold several jobs. And currently, that also affects their mental capacity to be able to take care of their needs with one or two jobs with that special permit. Then, managing human resources in health. For Guatemala, we've always had insufficient number of resources. We know specifically that the distribution is not very equitable. We see this where we concentrate on human resources in populated areas, areas of greater population concentration. They barely reach rural areas and not the remote areas as we might expect. We know that our policy and our plans, financial plans, do not enable us to be able to have wage incentives, specific salary incentives, such as some that could be offered in connection with the work done or the remoteness where they're operating. However, as a ministry, we can and we have been improving the payment of this personnel, but it has not been sufficient in order to be able to retain the personnel, health personnel in these areas. Our means available in Guatemala do not allow us to have these incentives, but we're also studying this and we are in a position to offer other incentives that are not necessarily monetary, but at some point we could use this as a form of a different policy that we could use and work on in the future. We try to reduce as much as possible the scarcity and shortage of personnel in rural areas, but that's quite a challenge for us in Guatemala. On this next slide, I'd like to share with you what our future steps are, what we intend to do. We know as Guatemala that it is extremely important to have a national development policy for the development of health of personnel and human resources. Fortunately, we already have a good work that has begun with the support of a cooperation, particularly with PAHO, on a national health policy that we've been working on in past years. Regrettably, because of the pandemic, it came to a halt at some point, but we're once again ready to restart it. And this will enable us to implement the administrative career with better working conditions than those that we currently have. Also, with this policy, we have to develop the profiles of the human resources that needed, not only in urban areas, but in the entire country context. We understand that we have to improve labor legislation in order to be able to offer better working conditions to our workers, strengthening the information system, which is quite important, and we're working on that to improve the management of human resource and health regarding their recruitment through the strengthening of the infrastructure, information infrastructure, which will enable us to become acquainted with the availability that we might have with the personnel in order to fill the vacancies that we have in the most rural and remote areas. Another important issue is to improve health infrastructure, not only the provision of health services specifically, but also in education. This will enable us to favor creating the work environment and the environment for family of health personnel so that they can have a personal satisfaction and to better concentrate on the care that can be given or that they would be ready to provide. And we also understand that this could be a way of retaining the health personnel. For the country, with the levels of poverty, it would be ideal. It is uphill, but we know that it is necessary. And this will enable us to offer a facility and a possibility to our health personnel to have a better income, perhaps in addition to the jobs that they've been hired to do or with the salaries that they're being paid for the work they do. We have also considered as another priority look for the adoption of salary bonds, particularly in work areas of difficult access, where because of reasons of climate conditions or the distance or the places where we find the most populated areas, this could be one of the ways of retaining the health of personnel. We've also considered reducing precarious employment, ensuring labor stability, and reducing the number of part time personnel, having to transfer these temp personnel to permanent staff, which in the future, in the very near future, will be of huge benefit for health personnel. And obviously, to reduce the gaps in human resources and health. So we're making a significant headway. We're coordinating with universities and training schools in order to support the training in quality and in sufficient number, and to be able to achieve the development of different places of quite remote areas, and understanding that we would like the personnel to be trained outside their places of our origin, so that we can give them incentives to continue working in their cities of origin, that they don't have to go to other cities to be trained, but to bring that training to the most remote areas, quite away from the capital or high population density villages or bigger cities, but to be able to coordinate with these universities and schools in order to bring that training to these most remote areas. And this, for the ministry, would also imply the creation of new jobs, vacancies, emphasizing these remote, neglected areas of high incidence of epidemiological factors. So, this is what we wanted to share with you. Maybe it's quite ambitious, or it may sound ambitious, but we know that as a ministry, we must do this and take concrete actions in order to improve the situation. We're willing and ready to expand or to answer whatever concerns you might have, and we're gladly ready to elaborate on them. Thank you very much.
Thank you very much, Dr. Meneses, for your presentation. Likewise, thank you, Sulma. In summary, through this webinar, we now have a vision as to what is needed regionally in order to ensure those resources are available to achieve universal health. From the evidence standpoint, we have some not that specific evidence for the interventions as proposed. Likewise, we're facing difficulties to implement the process. So more needs to be done on this topic. It poses many challenges even today for us to be able to assert that we'll be able to achieve universal health in the regions. I see 3 raised hands, but since our time is coming to an end, I would ask your interventions to be very brief and to the point so that we can allow the 3 people to speak. So please go ahead. Herbert Abarcanti, if you want to unmute your mic. Herbert? Herbert. I'm sorry, it was a mistake. I didn't intend to raise my hand. I do apologize. Belkis next. There's a hand raised for Belkis. Likewise, in my case, it was an error. I do apologize. And Raul Or Janet? Yes, I'm Raul Urquiza. I'm a doctor in the province of San Luis, Argentina. I want to refer to something that Sulma pointed out about a publication in 2021 about how to attract and retain health work personnel. Is that what the document specifically refers to? I hope you can hear me. Yes, indeed. It was published by the World Health Organization, and it looks into the interventions I referred to. It is available uh, and can be downloaded through the internet. Thank you. Jeanette, next. Jeanette Vega. Good afternoon. Can you hear me? Good afternoon from Nicaragua. In order to reduce the gap in Nicaragua and provide universal coverage, we have created or implemented a number of strategies, such as a university in the closer to the campesinos, working with the most distant and remote municipalities, provided training in nursing and medical training. In the case of nursing, we are training community aides. These are health brigades that had a 2-year training, and they remained working in their very own community. There were 2,000 new positions created in the ministry, and thanks to this, we were able to expand coverage. Then there is also access to different meetings. It was difficult. We had to fly, but nowadays it is possible to go by road. It's perhaps a 6 to 8 hour drive, but thanks to this, we're able to reach communities that were inaccessible before. As you pointed out, we still do face challenges, but we're on the correct path. And it's important to see these experiences in different countries in order to reinforce universal coverage. Thank you very much, Janeth, for that contribution and information. Felipe. Thank you and good afternoon. That's an interesting study. And I have a question. I wonder if during the study you were able to look into the instance of doctors in indigenous communities and also the traditional uh, medicine that are provided in those communities. I don't know, Zulma, but I think in principle you did refer only to published documents. I think there is very little of this other area, but I think it would be interesting to have that kind of information available and share experiences about policies that are used and implemented for those ethnic groups. Sulma, would you like to add something? Yes, with regards to non-traditional medicine, we found no literature. But yes, in the case of education, referring to students, who, even in the educational system, end up being trained with the idea of sending them back to their area of origin. In the case of Argentina, in the northern part of the country, in the province of Tucumán, the system has already focused on resending graduates from the indigenous communities back to their communities after they receive their training. There are other similar experiences, but in relative terms, the quantity and the level of evidence is extremely scarce. Thank you very much. And given the time, I would like to thank everyone who connected to this session, as well as those who participated. We remain available for any question you may have, or even more important, if you're able to share with us your experiences or specific experiences that you have seen in certain communities or in some other countries. All of that information will be most valuable. And if there are outcomes from those experiences, even if they're partial, it will be extremely useful and can become part of our process as we work on this policy document. Sulma, were you raising your hand? Yes, I have a comment, a follow-on comment. We could perhaps share an email where where people can share both their concerns as well as their experiences. I don't know if if we should give our email or what. So perhaps somebody could write the email into the chat. That way we can receive any information, and we'll be most grateful for hearing your comments, reading your comments, as well as your questions. Thank you very much for sharing that with us. We'd ask the panelists to remain connected after the participants have disconnected. Just 5 minutes extra for them. The interpreters are going to disconnect now.